Now let us talk about induction of labor. We are saying, when is induction of labor indicated? And we are saying prolonged pregnancy at 41 to 42 weeks to reduce perinatal risks. When we are sure that our mother is past 41 weeks, of course, we can do the fetal surveillance, but when we look at the fetal surveillance, when our parameters are not very stable, we can switch to induction of labor. When this mother comes and tells us that there is a history of unexplained intrauterine deaths, this mother is having a history of unexplained intrauterine deaths and her pregnancy is at 41 weeks, we better induce this mother and have a live baby than prolonging the pregnancy and get other risks. Then chronic medical conditions like renal, respiratory, or cardiac diseases. We can think about inducing labor when this mother is having these medical conditions and her health is not able to sustain the pregnancy, irrespective of the gestational age. What does it mean? That we can even induce labor when it is not yet 41 weeks, depending on the maternal condition. Then we have intrauterine deaths, when the baby has died intrauterine, irrespective of the age. Of course, we shall induce labor and we expel such a fetus. When we think that there is polyhydramnios, we shall also induce labor. Congenital abnormalities, as these mothers are doing scans and we are having that these babies or the fetus is having extreme congenital abnormalities. For example, when the mother is having an encephaly, we can counsel the mother and tell her the prognosis, if this baby is born, what will happen, etc. And if the mother wishes, we can carry out induction of labor irrespective of the gestation age, and this mother expels this baby with extreme congenital abnormalities. Then we have placenta insufficiency, which can be detected at any age during pregnancy. Of course, instead of allowing this baby die intrauterine, we rather induce the baby, and we have a live baby. Then we talk of eclampsia or severe preeclampsia. This is one of the commonest causes of what we call therapeutic abortion. When we have done everything, the pressures are shooting, the mother is going into end organ damage, edema is plus, protein in urine is plus, the mother is having blood vision, we have given all the drugs, hydralazine, magnesium sulfate, etc. But the pressures are not coming down and the mother's life in danger. We can choose to do induction of labor at any gestation age, irrespective of whether we get this baby alive or not. We shall carry out an induction to save the mother's life. And also, if the mother comes and complains of premature rupture of membranes, that is when the membranes rupture even before the onset of labor, so we can decide to carry out induction of labor. So all those are indications of induction of labor. How about the contraindications? When should we not carry out induction of labor? 1, when we have a cyst and the maternal pelvis is contracted, so we don't dare carry out induction of labor. When we have malpresentation, the baby is in oblique, the baby is in transverse, so why should we induce this mother? Because ideally this mother will not push this baby, so we don't do induction. Then previous cesarean section, when this mother has a previous cesarean section or even a previous scar on the uterus, either myomectomy, anything related to the previous scar on the uterus, we don't carry out induction of labor. Then cord presentation and cord prolapse, so we must do a scan and see what is presenting first. If it is the cord, please never suggest for an induction of labor. When we talk of placenta previa, this is a low-lying placenta in the lower uterine segment. We don't. Pelvic tumors, example like fibroids, they can be cervical fibroids, they can be every kind of fibroid in the uterus. We may not do induction of labor. So before we carry out induction of labor, we must properly assess this mother and find out the parameters which may give us a go ahead. Okay. So we are also going to look at the methods of induction. Of course, we have very many, but we can look at a few. The first method is called cervical ripening. And cervical ripening will be done if we have a Bishop score which is less than 6. Now, what is a Bishop score? Like when we say Apgar score, people, when we say Apgar score, think about appearance, pulse, etc. And it is a method of assessing the condition of the baby at birth. But now, what is the Bishop score? And the Bishop score is a sign to assess the state of the cervix, whether it is ready for labor. And here is the explanation. A Bishop score is a system used by healthcare providers to assess the readiness of the cervix for labor and predict the likelihoodness of a vaginal delivery. So we shall carry out cervical ripening if our Bishop score is less than 6. And here is how we are going to do it. So under the Bishop score, we have 5 components. We have cervical dilatation, that is the opening of the cervix in centimeters. We have cervical effacement, that is thinning of the cervix, which is always calculated in percentages. Cervical consistency, here we examine the firmness of the cervix. Cervical position, that is location of the cervix in relation to the vaginal canal. So you look at all these 4 parameters, we are talking about the cervix, nothing else but the cervix, because it is which must dilate and the baby pass. And then lastly, we shall talk about the fetal station, that is position of the baby's head in relation to the ischial-spines of the pelvis. And here we go. We are having parameters that are 0, 1, 2, and 3. So for the first one, we are looking at cervical dilatation. Of course, we shall make a VE and find out if the cervix is completely closed, we shall score that 0. If the cervix admits a finger, that is 1 to 2 centimeters, we shall score that 1. And if the cervix admits 2 fingers, that is around 3 to 4 centimeters, then we shall score that 2. And if the cervix admits is greater or equal to 5 centimeters, it means we shall score that 3. Then we shall go to what we call cervical effacement. And cervical effacement, we shall measure it using our 2 fingers. And I don't know whether you can see my fingers. You usually make a vaginal examination by 2 fingers. And what we are examining for is how is the cervix being dipped into the vaginal canal. Remember, we have the anterior and the posterior fontanelle, fornices. So if you make a VE, you fill the cervix into the vagina. And when you fill the cervix in the vagina, you use your middle finger and try to measure what is the part which is dipping into the vagina. If you look at your middle finger, it is having 3 demarcations. And each of these 3 demarcations, we shall say it is 25%. So, if we are still filling the cervix into the vagina, for example, when I make a VE, it is only one part of the finger, only this thing which is bending, only. How can I explain now? Okay, when you make a VE and you feel that almost all your fingers, you are still feeling the cervix into the vagina. Remember, I said each of these is 25. It means we need one more part to make 100%. So what does it mean? If I make a VE and I still feel the cervix into the vagina, the whole of my fingers are feeling the cervix into the vagina, then it means this cervix is only 30% effaced. Or I can say 25%, because this is, each of this is 25, then this is 75. 75 minus 100, then it means we have 25 to 30%. So when I still feel the whole vagina into the cervix, that means it is only 0 to 30% effaced. So at one time, and that one I'll score 0. Then at one time you can feel the cervix being taken up, and you're only feeling it into the vagina with only these 2 bits of the finger, and it's only what you are feeling into the vagina. It means this cervix is 50% effaced, taken up. The word effaced means taken up, and it is being taken up at the upper side. So when it is 50% effaced, then I will score that 1. And then when you make a vaginal examination and you only feel this tip, the small tip, only when you are just tipping the vagina into the cervix with only this, then it means you are above 75% effacement. So we shall score that 2. And sometimes you can make a vaginal examination and know where you are feeling the vagina, know the cervix into the vagina. It means the whole of the cervix has been taken up. So that is 80%. And that is 80% effaced. We shall score it 3. We shall understand these things more when we do the practical. So when we look at consistency, again, as you feel for the vagina, for the cervix into the vagina, you assess, is it so strong? Because the nature of the cervix is as hard as the tip of the nose. If you feel it is so hard and firm, that it means the consistency, we shall score 0. Then if it is medium, we shall score it 1. Soft, we shall score it 2. But remember, because the cervix is effaced at 80%, you may not feel the consistency. You may not be able to feel for the cervix. Then that is dash. If you have dash, then you are having a score of 3. Then again, we look at the cervical position. Remember, the cervix dips into the posterior fontanelle. But as it tries to be effacing or taken up, it tries to come into the middle and then later it will be all taken away. So if you still palpate the cervix into the posterior fontanelle, when it is dipping posteriorly, then it means you shall give a score of 0. When it is coming around the middle, you shall give the score of 1. Anterior, you shall give a score of 2. And then when the cervix is not on, we shall give a score of 3. Then we go back. We assess the fetus in relation to the ischial spine. And when we talk of the ischial spine, it is a landmark of the pelvic outlet. And the ischial spine is at 0. So anything felt above the ischial spine, that is negative, and anything felt below the ischial spine, that is positive. And how am I going to explain this? Again, we use our fingers as midwives. And we are going to assess at the level of the ischial spine. And as we assess the level of ischial spines, we try to go up and try to find the fetal head. And if the fetal head is up at the brim, then that is -3. And that one, we shall score it 0. And now when the head is trying to come down nearer the pelvic outlet, and we are tipping it with our finger, then we shall say it is -2. So we shall score that 1. And when the head is coming nearer the ischial spines or at the ischial spine, we shall say that the fetal station is 0. And we shall score it 2. And it means if the head is at 0, it is entering the pelvic outlet. That means if it comes to +1, it means the head is already out of the pelvic outlet. So it is below the pelvic outlet, and we shall say that +1 or +2, and we score 3. So after doing those assessments, all these assessments, we shall do them on vaginal examination. So we shall start to add. We shall say maybe factor 1, that is dilatation, is 0, effacement is 1, consistency, for example, is also 1, those are 2. Position to Gambe is 0, that is, we are still at 2, and fetal station, for example, is at -2, that is 1. So the total score is now 3, which is less than 6. It means our bishop's score is less than 6. Then we shall think of cervical ripening. We shall do something such that the cervix ripens, becomes more soft, which will be helping us to deliver successfully.